Good afternoon and welcome to the Senior Hour, which is sponsored by Comfort Keepers in Home Care and Providence Holy Cross Medical Center. I'm Barbara Cochran with my co-host,
Dr. Jean Dorio.
On your hometown station, 98.1 FM, AM 1220 KHTS. This is a show for, about, and by seniors, giving information to enhance one's quality of life. And speaking of quality of life, our guest today is Sondra Wollenman. She's a palliative care specialist from Providence Holy Cross. It's good to see you again.
Welcome, Sondra.
You too, Barbara.
Welcome.
Thank you. Thank you so much for having me.
Yes. So you have lots to talk about. Or we have lots to talk about.
Yes.
So I know your counterpart at Providence for years, probably over a decade now. And,
Aw.
you guys do a wonderful job
Thank you.
down there. And, we always try to at least bring people up to par with their understanding
Right.
of medicine, because it's a difficult subject. But palliative care, when one says palliative care, what does that mean?
Yeah. Thank you for asking. So it can be scary sometimes because we're still confused with hospice care and we're not hospice care. So palliative care is really an area of medicine. We're a medical specialty. And what we do is care for patients that have chronic or serious illness. And we do whole person care. So we look at the person as a whole, not just their specific medical condition that they're dealing with. We do a lot of symptom management. We look at issues they have psychosocially, spiritually, and we also do advanced care planning. So we're doing advanced directives and pulse forms to speak to what their medical wishes are for the future. So we really take care of the whole person, while the majority of times, the patient's goal is still to receive active, aggressive treatments, and sometimes curative treatments for their conditions.
It's kind of sad that we talk about whole person, because
Yeah.
doctors in general should be already treating
Yeah.
their patients as a whole person.
Right.
But yet in this day and age, I can walk out in the street here in Newhall and ask, how are you being treated by your physician? And many of them will say, who's my physician? I don't know.
Yeah.
It's not one of these personal things now that you need to have in your life. Your minister, your doctor, your nurse.
Yeah.
You want to know who they are too.
Yeah, for sure.
But these days it's not that way. So the whole person,
Yeah.
when they sign up for palliative care, they're
Yeah.
not signing up for hospice care. They're signing up for palliative care.
Yeah.
Unfortunately, having been in the field
Yeah.
and knowing the problems that we have all faced, the question, now is how medicine has become a business.
Yeah.
And part of that business, in the very beginning, when palliative care was just emerging and hospice was just emerging, people didn't know how to, they didn't understand it.
Right.
And so I guess my question is, how do patients, and you're not going to face it, you're going to hear it here on the radio today, but how does one face, a dire situation when a loved one is possibly having a life-threatening illness, and how does one just, it's hard for them to jump into it, and know exactly what to do. What is your approach, Sondra, when your team gets in there and does a great job that you guys do? How do they go about doing that? How do they rev up and find that whole person again?
Yeah, for sure. So I think we're doing a much better job at educating not only patients and families, but also clinicians. And part of that education is who we are and what we do. And also we try really to educate to say, consult us earlier in a condition that is going to be hard to deal with, like pancreatic cancer. The studies have shown that when we get consulted really at time of diagnosis, it's not as scary. We can make those connections. We can develop that rapport with patients and families, and we can follow them throughout the trajectory of their illness. Our involvement with them starts off kind of small because they're really, the majority of care is with their oncologist and things like that. And then we continue to follow them through the course of their illness. And then our involvement becomes more and more as they get closer to end of life. So really, palliative care, when done in its best way, is done that way. But, you know, sometimes it's not. And our area of medicine, the key thing when you're a clinician in this field is just really meeting people where they're at. So it's a unique area of medicine where you don't know what you're going to get. People are at different stages of understanding and acceptance. And I just work to, you know, meet people where they're at, ask them questions, figure out what they're willing to hear at that point, and support them. So yeah, it's really individualized based on what the person
So palliative
needs.
care comes
Yeah.
before hospice care.
Yes, we hope so.
So, well, how far into an illness or a person's
Yeah.
anticipating death, how far into that do you go before you recommend hospice care?
Yeah, that's a good question. So it's two things. It's who the person is and what they want for their life and what they want for their care. Some people, when they're presented options for their care, actually don't want to forego aggressive treatments and would rather go to just a comfort-focused approach. So that's one thing. And then the second thing is what's medically indicated for them. So there is a point where, unfortunately, a person cannot receive any further medical treatments because they're too ill. There's no further treatments available, and the best thing we can do for them at that point is provide them with
Put
hospice care.
Hospice care.
Yeah.
I see.
And that
So
is not an easy
Yeah.
decision at all, is it?
No.
Barb, you're asking a great question. That transition going from palliative care, which is help guiding the patient, into a different arena of hospice care. And that, you know, that's what we should elaborate on in this discussion, because I don't think that a lot of the listeners and even the doctors don't even know
Yeah.
what one should do on the next step. And
Yeah.
as doctors try to hold a patient and family's hand, you know, many times that's out the window.
Yeah.
You know, let's talk about a different side, and you alluded to it, and I know that you guys do a great job, but in the LA Times, they had some serious discussions about palliative care companies putting people right into hospice, and then hospitals and health insurance agencies washing their hands financially of those patients. And that, to me, is a crime.
Yeah.
And
Yeah.
it took place early in the process
Right.
of healthcare in this country, probably maybe 10 years ago now.
Yeah. Yeah.
And a lot of these companies were exposed, thank goodness.
Yeah.
But, you know, it's still out there,
Yeah.
the confusion, isn't
Right.
it, Sondra? And how do we make sure that the confusion doesn't interfere with good decision making?
what do you mean by confusion? Confusion about what?
Direction to go in terms of medical decision making.
And isn't that up to the doctor?
No, the whole idea is this, to have a communication with the wishes of the patient and the family versus what the doctor knowledge and medical knowledge as
So
well.
that's palliative care when a person is in that situation.
Well, it's palliative care when there is a life-threatening illness
Right.
and you have a patient that might be suffering, but also has specific wishes that they want to sustain in their life,
Yeah.
and allow those decisions to be made. So palliative care is, you know, moving forward with someone holding your hand, medical experts holding your hand. What we're talking about here is we don't want someone who doesn't care about the patient, who looks into just their finances as being the most viable option. You want to be able to have good rationale, good medical decision making, so that people can move forward. And if they need to move on to hospice care, they can. But if they don't, then they can continue to battle their illness
Yeah.
in a logical, good, worthy, and hopefully less suffering way.
So that's what happened with Russ then. He was in palliative care for, 5 weeks at Henry Mayo
Right.
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 until the woman who was in there
Right.
suggested this is getting worse and worse, and it's not going to get better.
Yeah.
And so let's call in hospice care.
Yeah.
And and I remember those days with Russ, and I still allude to the fact that as doctors, my initials are GRD, not GOD, and because I don't
That's a good
always
one.
know, but I do know that in my time as a physician, I could tell that a patient was ill enough to where they were not going to recover.
Right.
And most of the time, my patients, I can say, and trust me on this, that no patient was on hospice longer than 8 days. That's it.
Yeah.
And, a few years ago, you used to hear about patients being on hospice for 2 years, and that's a crime. And that I don't think they've fixed it, but they are judging it now, and
Yeah.
thank goodness, in a different way.
Yeah.
But yeah, we want to make sure that when one is facing a medical issue, and they even might be suffering, maybe they're not suffering, but you want to make sure that their decision making is good,
Yeah.
and to have the guidance
Right.
to be there. If you don't, and many people don't, they don't have someone in their back pocket that say, hey, Dr. So-and-so, what do I do now? It doesn't work that way. A lot of it is flipping coins and trying to figure out from the internet what the best thing to do is. And some of that is wrong. So palliative care is so helpful
Yeah.
to our patients, but it has to be used
Yeah.
correctly. And, now great companies like Providence, they've made sure that they've kept the guardrails up
Right.
and made sure that people who get the appropriate care are going to get the
Yeah.
appropriate care, and it will not be based on their insurance company or their
Right.
finances
Yeah.
or anything like that.
Well, now Henry Mayo doesn't offer that, does it?
You hear silence.
Yeah, I'm not. I'm not sure about
And
Henry Mayo.
I am sure, but
Oh, okay.
you still hear silence. So, my point is, so a good question, Sandra.
Yeah.
How does one realistically determine a good palliative care or hospice care provider?
Yeah.
How do we do that? I mean,
Yeah.
with Medicare, there's 5 stars, right?
Right.
But are there 5 stars for hospice?
Yeah. So, it's a little tough. First of all, you alluded to it. There's many, many, many hospice companies out there. Some of them are good. Some of them aren't so good.
What does that mean by aren't so good? What does
So
that mean?
Medicare, so hospice is a Medicare benefit. So each hospice company will get a certain amount of money per patient, and how they choose to spend that money is up to that hospice company. So it is important when we recommend hospice, we do have a case manager that presents the patient and family with hospice choice. So they have a choice, and they can look into the companies and figure out what's best for them and their family, because there's certain hospice companies that will offer certain medicines, and then there's others that won't. They make their decisions, how they want to allocate their funds.
So it's up to the patient to make the decision.
So we guide and provide choice, but then the families can look into which company they'd like to go with, and that is a law that you do need to provide choice, so people don't feel stuck with one company.
Right.
Yeah.
Oh, interesting.
Yeah. As far as palliative care goes, that's a little bit different, because there is different medical groups and things like that have their own palliative care, especially outpatient palliative care companies that they normally direct their patients to.
And we're just
So-
alluding
the
back.
hospital refers them?
So we at the hospital will refer to home-based palliative care. Providence Holy Cross does have a home-based palliative care group, but if a patient is under a certain insurance and a certain medical group, that medical group may guide them to the company that they use.
Oh, I see.
Yeah.
Is
yeah.
it possible that some insurance companies don't cover palliative care companies?
Most do. So I'm finding more and more that most do, because it is actually something that I think is, we've all talked about it. It's very beneficial to patients and families, but it's
yes.
also fiscally responsible because it does support patients outpatient. They kind of intervene and decrease the need for hospitalizations and things like that. So it's fiscally responsible for
What about those
everyone.
patients that are in nursing care in a facility?
So in a skilled nursing facility, palliative doesn't follow there. So if a patient goes to a skilled nursing facility,
Nursing home.
we could write an order for palliative to check in, because some people just go to a nursing facility for like 1 to 2 weeks for physical therapy and things like that, and they eventually go home. So our home-based palliative can touch base with them once they're home. But palliative only follows when a patient's either home or in a board and care.
Okay.
Yeah. You can get hospice at a nursing facility if you have the insurance coverage for it. Yeah.
Interesting.
So what we were alluding to, though, Mike, is that, there's been trouble with palliative and hospice care,
Right.
and it's been written about. So you can go online and,
We've seen it too,
I'm just so happy that Providence Holy Cross has sustained a high level
Yes.
and standard for their patients who might be having life-threatening illness.
Yeah.
I mean, think about, some of the companies, Barb, 10 years ago, they're the fastest growing licensing group in the state of California was professional licensing was for hospice care. And all these companies came out
Yeah.
and they found that the money that was going into it was being utilized to buy big mansions and fancy cars, and
that's
and
what
that
I'm
was
talking
our
about.
taxpayer money.
Yeah.
I think I
Yeah.
remember
Yes.
reading about that.
We may
yes.
have even talked about it
Yes.
before. Yeah.
Right.
So
There
it's,
is more regulation around it
Much
now.
more.
I am noticing that Medicare is following up with these companies more and more. There's more oversight, so that's a good thing.
it's a good thing, but we need to,
Yeah.
through this radio show and good discussion,
Yeah.
we're able to clarify the lines that are drawn
Right.
so that, if someone out there is stepping over that line, we can push them back and say, no, I don't want your agency. I've looked you up and, there's been trouble with your agency.
Right.
And that's what we want. We want clarity. We want, if someone's going to hold my loved one's hand, I want somebody who's going to be legitimate.
Of course.
And I
Yeah,
think
it's
all
important.
of us want that, but there are
Yeah.
some people that just don't have the scruples,
Yeah.
and we have to be mindful of that and be
Right.
watchful, have good oversight to make sure that our patients, especially here in Santa Cruz in the Valley, get good care. And
Yeah.
I think through
Agreed.
your organization, they're getting not just good care, but great care.
Thank you.
We
Yeah.
appreciate that.
Of course. Yes.
Interesting.
Definitely.
Barb's saying it very interesting, and it is. It's interesting that government made a program which is on paper looks great, but when you really
Actuality.
when it went into practice, there was theft in it,
I
and you wanted to trust the people who are involved with it. And my brother, who is a hospice doctor, he tells me,
Right.
all the scandals that have gone on
Right.
within the agencies, which is very sad. Which is very sad.
Now,
for
does,
sure.
does do most long-term care insurances cover palliative care?
The
Insurance-wise?
Medicare covers it.
Oh,
So
Medicare covers it.
so I think almost every agency that I know of.
All
I-
insurance companies pretty much have their own palliative care group at least. So.
Yeah, because I have long-term insurance with MetLife,
Uh-huh.
and when I had my first cancer attack
Right.
and had to stay at home, my daughter, I think she called you, didn't she? Didn't Dee Dee call you to find out if I should go on long-term care insurance, and you
Oh,
said
oh
no.
yeah, yeah.
Yeah, I thought you did, and you said
Mm-hmm.
no.
Yeah, I said no to the
Yes.
question, yeah.
Yes. Interesting.
Well, we're just having a great conversation with
Yeah.
Sondra Wollenman from Providence Holy Cross. But we're going to take a break, come back with some more enticing questions maybe as well. But, I think, Barb, what this community shows is KHTS is pushing the pole up, the goal posts, so that we have better care
Yes.
in the Santa Clarita Valley, which I
Yes.
think
Yeah.
we have achieved here with Providence Holy Cross.
Yes.
So we're going to take a break. I'm Dr. Gene Dorio with my co-host Barbara Cochran on your hometown station, 1220 AM and 98.1 FM, KHTS.
Welcome back to the Senior Hour. I'm Barbara Cochran with my co-host
Dr. Gene Dorio.
on your hometown station, 98.1 FM, AM 1220 KHTS. And our guest is Sondra Wollenman. She's a palliative care specialist at Providence Holy Cross. And what an interesting conversation we've been having. It really is.
Yeah.
And, talking about cancer, I've beaten cancer twice, and I'm on my third. I have, what's the name of that again?
Melanoma.
A melanoma up here. And I have to go in on Friday Friday, this coming Friday.
Okay.
And they're going to determine where and when I'm going to have this cut out. Because when I told Dr. Black about it, that I was going in for radiation, he said, "Don't you dare do radiation. You need to have it taken care of."
Yeah.
He said radiation and I was going to have it 5 days a week for, I think it was 3 weeks. And he said that will totally destroy your body. And at your age, you do not have radiation.
I've been there. I went through 8 weeks of radiation. 10 minutes a day for 5 days a week, and it does.
Yeah.
It's a lot.
And
yeah.
I handled it well, but again, the after effects go on for years. Lymphedema.
Well,
and
that's
Yeah,
what have you.
that's
Yeah.
what he said.
But
So-
your hand was being held by Dr. Black,
Yeah.
The
Alex
doctor.
Black from UCLA,
Mm-hmm.
who's a great oncologist,
Oh, yes.
who has helped many hundreds of my patients.
Beautiful.
And so you are in the right hands, Barbara.
Oh, yes, I know that. I
That's
know that
good.
now. I really do. So I'm going to have it cut out.
That's good.
So
Yeah.
So
I'll have
going
to
back
walk
to
around with something over.
Like a pirate, yeah.
Yeah.
But the other thing too is he found a polyp. I have to go through 2 different procedures, which I think it's not this Friday, next Friday, to determine whether or not it is cancerous. And that was through Dr. Black again.
once again, decision-making, medical decision-making is
Yes.
critical
Yeah.
for all of us. And
Oh, yeah,
when-
and
and you don't have to get an MD to be able to make these decisions.
Right.
There is logic in medicine.
Yeah.
When I went to medical school, the only thing I memorized was anatomy. That was it. Everything else was common sense and logic, and it still is. It hasn't changed. You just have to be able to back it up with some substance, some evidence base if you can.
Yeah.
Well, I have
Yeah,
to.
for sure.
I have to go through those procedures.
Yeah.
I mean, I'm 89. I plan to live until I'm 100.
Oh, you will. You will.
That's good.
That's my plan.
That's great.
But
yeah.
I need to have this taken care of.
Sure.
And again, you hear the word cancer, and it's overwhelming.
Oh,
it really
tell me
is.
about it. I've had it
Because
twice.
the journey
and I've
begins.
got it again.
You know,
But I beat it twice. I'll beat it 3 times. So there.
you will.
Is that understood?
It is understood. We got it.
Gene was there when I went through it.
Oh, yes.
You know, and
yeah.
here I am, 15 years later. I'm doing
Beautiful.
and you're
great.
Oh, good.
you're doing great, though,
Amazing,
Mike.
yeah.
That's super.
Yeah. But
So-
it is a journey, and again,
Sure.
knowledge as well. And one thing on hospice I wanted to mention as well:
Yeah.
are there facilities or counties that try to push people into hospice too soon? Does that happen?
I mean, we've seen people that have been signed up for hospice inappropriately, I would say. And I would agree that knowledge is power. Hospice is very specific. You have to, in order to qualify, you need to have a terminal disease
Right.
diagnosis with a prognosis of 6 months or less. So we have seen people with diseases like heart failure and things like that, but definitely not with a prognosis of 6 months or less signed up for hospice. So we catch those things and we re-educate, and then we sign them up normally with home-based palliative care because that's more appropriate.
Right.
So just knowing that piece is important. Because sometimes physicians or providers might not fully grasp that. We do get consulted sometimes in the hospital and asked for hospice, and we say no, they don't qualify. So having that knowledge is important.
That was my
Interesting.
duty as a doctor.
Yeah.
Was to
Yeah.
go out and evaluate. I was asked
Right.
by hospice agencies to evaluate patients as to whether they actually did qualify by agencies that were good, whereas others were a little bit questionable,
Right.
and they didn't want to go through the hassles of being judged by like Medicare
Right.
that somebody was not a valid patient who they were treating. And so my duty, and I can tell you,
Yeah.
and that's where I got my experience and my learned ability to understand there are some people cheating out there.
Yeah.
Yeah.
And we had
Yeah.
my duty was to not only expose them,
Yeah.
but it was to make sure that
Yeah.
those agencies who are doing a great job,
Yeah.
like Providence,
Right.
would get the work and be able to take care of my patients.
Right.
And so we did that. My brother does that. I do that.
Yeah.
And this is a valuable part of our society that we have.
It
I
is.
wouldn't call us a whistleblower. We're evaluators asked by legitimate companies to look at patients and see whether they're eligible or not.
That's good.
And to me, that is the way checks and balances.
Very
it
good.
works. Putting the guardrails up.
Yeah.
It works. So
It's very important because hospice is a beautiful benefit for
That's
patients when they need it. I mean, patients sometimes will live longer with a terminal illness because we're focusing on their comfort and they're able to spend time with family at home. So it's a beautiful thing when it's done in its right way. But yeah, when people take advantage, that's not good.
Jean, you're a geriatric doctor, so you probably see more elderly people who are going through palliative care and hospice care.
Yep.
So you're able to recommend both of those.
exactly.
That's great.
And that's been my job for my patients.
Yeah.
And the most valuable part about being in Santa Clarita, we have a closed community
Yeah.
in the sense of, we're in a valley, Santa Clarita Valley,
Right.
and I was able to do house calls for
Aw.
as long as my practice, 30 years
Oh,
that I've been in 34 years that I've been
Wow.
practiced
That's so
in Santa.
nice.
But right off the bat, I was doing house calls.
Right.
But when you do house calls, a different viewpoint
Right.
of where those patients, where they come from, where the families come from.
Totally.
And to be honest with you, I think there are a lot of things that we should be doing, but one of the things that I've advocated, and no one's taken me up, I've been on a national podcast saying
Oh, cool.
everybody, doctors, you young doctors, should do house calls as part of your duty.
Absolutely.
Yeah.
But they can't seem to get away from their computers.
Yeah.
And I can understand that. The paperwork is tremendous. And, my house call patients, I had a computer that I took around with me, and, the Santa Clarita sun in the summertime, 120 degrees in the car.
Right.
And
Oh,
so
dear.
I didn't want to, be buying new laptops,
Yeah.
day and night. So,
Right.
but, I think one of it is convenience. One of it having the computer by your side. Those are okay excuses, but if you really want to know your patient and then eventually be able to really help them in decision making,
Sure.
you need to know where they come from.
Yeah.
You need to know their background. I walk in, I look at the walls, see the pictures of their family, see the piano that might be there, the
And
cat that's
that
feeding.
gives you a
Yeah.
lot of information on as far as treatment goes. Also,
Absolutely. Like Russ
Who
and
they
his
are.
violin playing.
Yes.
Who would have known that he played the violin?
Aw.
And being left-handed like
cool.
Barb is, to know that he was
Beautiful.
and I don't think anybody on his school boards or anyone knew that he played the violin, but when I went to their home,
you saw.
I saw photos of him with his violin.
Mm,
So,
beautiful.
yeah, you get a different
Yeah.
viewpoint,
Yeah.
which I think is important. And
Yeah.
that's what happens when you have home palliative care. You
Right.
get to go,
Yes.
when you see them in the hospital,
Yeah.
they're in their hospital bed and gown.
Right.
You don't know who they are.
Yeah.
That's
But,
right.
when you,
Yeah, the continuity of care is very important with
Great.
home-based palliative care because you're right, there's a lot of things we can't do in the hospital. Sometimes we can't even have a good conversation about goals of care and advanced care planning because it's such a heightened, acute situation that they're going through that it's hard. There's a lot of emotions. There's a lot going
Yep,
on. The
yep.
people are pretty sick. It's hard to
You've
get
got-
down
You've
to
got nurses walking in and out,
Right.
and doctors
Yep,
coming in and
Yeah.
out.
Yeah.
And you can't have a personal conversation.
it's tough. Yeah. So just
Whereas
making
you can do that when you go to their home.
yeah, exactly. Yeah.
Makes
So
a big difference.
making
really
that
does.
connection is important because then our home-based palliative care colleagues can sit down with them at their table in their house, fill out their advanced directive, talk with them really about what's important to them, what their goals are, and then obviously continue to follow them throughout their journey. So very, very
It really
important.
makes a big difference.
Yeah.
huge,
Yeah.
huge.
Yeah.
But why doesn't our society think that this is important? I don't
don't
know, but
understand that.
like I
really
said, I
don't.
was in a podcast, a national podcast
Right, right.
of doctors, and I spoke for an hour, and just tried to say,
Yeah.
if you want to know anything about house calls, let me know. You know how many phone calls and emails I got? Zero. And that's kind of sad. And it's not
it
that
is
zero
sad.
people were listening. It was national, so most of the medical schools in the United States, young students were listening, but nothing. So, but I think it's a different aspect of medicine that I think many people would enjoy. We have a doctor shortage,
Yeah.
and it doesn't mean that we have to get them doing house calls, but we can improve on that. We can
Yeah.
Well,
get more
you're
doctors.
You're still seeing patients, aren't you? Don't
Well,
you have
because of
certain
Robin's
ones?
illness, I've cut back. I've had to cut back because of,
Right.
it would mean apportioning some of my time somewhere else, which I did not want to do
Sure.
because her illness was life-threatening.
Right.
So for those listening that know who Robin is, she's doing okay. She's doing okay. We just came back
good.
from MD Anderson in Houston, Texas, and it's a clean bill of health, but they won't say that she's cured. That's just the nature of the illness, and that's where she's not on palliative care, nor has she ever been on hospice. But
Right.
we understand the situation, which where we've taken care of, and it's important that we have the medical background
Right.
to be able to have that knowledge, but you don't want to make mistakes in the process. And I think the information is out there. I think some of it comes through the doctors and nurses, but much of it comes through logical thinking, family meetings, even awareness. I hate to say it, but yes, you can get decent information sometimes on the internet. So,
Well,
that's
I
just what
would-
you have to do.
I would rank that on the bottom.
It's slow. It's slow.
I
Don't, you have to have a wary eye,
Yeah.
whenever you're looking at information from
Right.
the internet.
Right.
Especially with AI.
Yeah,
too.
especially
Oh,
with
sure.
AI.
Yeah.
Yeah.
Yeah, you don't know what's true and what's
I
not
don't
true.
get
Right.
any information
Totally.
on my computer.
Yeah.
I don't do it.
Right.
I'm not on any of those, what do you call them? Those
Threads or
programs.
websites or
Yeah,
Yeah.
I'm not on any
And
of
I guess the
those.
jury's still out as far as all these medicine ads on TV for prescriptions.
oh gosh.
I mean, it's just like inundated.
Oh,
Yep,
I know.
yep.
I'm wondering if doctors really agree with that.
Oh, I don't.
Yeah.
Absolutely not. And I think they make up diagnosis, don't you think?
Yeah,
Sondra,
I really don't think, companies should be advertising medicines to patients to bring up with their physicians. That's a little bit strange.
And some of the medicines Robin's was
Yeah.
$30,000 per month.
Oh, jeez.
Right.
Per month we're talking about. A little pill,
Yeah.
costly.
Yeah, but I totally agree. We are partners in care with patients and families, and patients know where they're at, and they have a lot of good information to give to us, and then we can make that shared decision making together. So the patients and the family's role in their life and what's going on with them is invaluable. Obviously,
We're still rolling along here, Sondra.
Yeah.
Great discussion, I think, and
Cool.
but we need to
Yeah.
take another break. I'm Dr. Gene Dorio with my co-host Barbara Cochran on your hometown station, 1220 AM and FM 98.1 KHTS.
Welcome back to the Senior Hour. I'm Barbara Cochran with my co-host
Dr. Gene Dorio.
on your hometown station, 98.1 FM, AM 1220 KHTS. And we've been speaking with Sondra Wollenman, who is a palliative care specialist. Boy, that's a mouthful. Palliative care.
you do a good job.
Yes, thank you. And she's with Providence Holy Cross
Yeah.
Medical. So let's kind of go over what
Sure.
palliative care is.
Yeah. So again, palliative care is a area of medicine, a specialty of medicine like cardiology or nephrology, any other specialty area of medicine. And what we deal with is patients who have chronic or serious illness, and we provide supportive whole person care. Normally when the goal of the patient and family is still to continue to receive disease-modifying treatments.
Not ready to give
Yeah.
up.
Not ready to transition, either not ready to transition over to hospice or
Medically.
or not medically ready. Yeah. Whereas hospice care is only specifically end of life care, symptom management only, where that just focuses on quality of life when a patient has a diagnosis of 6 months or less.
And
6
the
months
important
or
thing
less.
about this whole discussion was
Yeah.
having a relationship with your doctor,
Right.
which is ultra difficult these days.
It
But
is
you
critical.
I think you can, if you can anticipate your need down the line, and some of that comes from getting older. The senior hour, we're getting older. But to
Tell
be
me
able,
about it.
but to be able to understand what your needs might be,
Right.
not that they are now, and not getting into a situation where you end up having to make rash, quick decisions, and snapping your fingers, flipping a coin type
Right.
decision. It becomes uncomfortable
Yeah.
because you think, am I making the wrong decision?
Right, exactly. I think it's all about communication and relationship, as you said. Very important to have a primary care physician, one person that's managing all aspects of your care and that knows you. And then also very important to do your advanced care planning, do your advanced directive, and make your wishes known, write them down on paper and make them known with your family, and have good communication, amongst your family and your healthcare providers.
And that's the hard part, having that discussion,
Yeah, it is.
to be able
Yes.
to talk to your patients. But once again, I reiterate, for all you people who might be thinking about going to medical school, you young doctors
Yeah.
out there, think about doing house calls, because it will give you the pulse of what the patient wants, the
Right.
family wants, and you'll have a better understanding how to navigate for them their future and making good medical decisions for them.
Oh, yes.
So,
They've done it in England for years.
Oh,
Even
okay.
when I was over there, I came to the States when I was 10 and a half.
Wow.
But even my parents, when they got ill, the doctors came to the home.
Oh, wow.
It was all that. There weren't any offices to speak of.
Wow.
So
the
it-
doctors visited.
Yeah.
So, Sondra, is there a way that the public who might be listening right now might be able to contact you if they have any further questions?
Yeah. So I work with Providence Holy Cross Medical Center. We do have a website that would probably be the best thing to go to, and you can get our information there. If you're interested in palliative care and you live in the community, I would always recommend going to your primary care physician and asking for an order or referral to be referred to home-based palliative care.
Wow, Sondra.
Yeah.
Sondra Wollenman, just a great conversation
Aw,
today.
Thank you. Thanks
Very
for having
interesting.
me.
I think it was worthy for the
Very
KHT
informative.
and Santa Clarita Valley to hear. We are sponsored by Comfort Care Keepers In-Home Care and Providence Holy Cross Medical Center. Listen to us next week on the Senior Hour. Now go and enhance your quality of life.